Welcome, everybody. So what I'll be talking about is the emerging role of artificial intelligence in the practice of breast pathology. And I have several disclosures as shown here. So why are we talking about AI in pathology? Well, as we all know, pathologists are too few in number. We're required to do more and more, and we're overworked. In fact, there was a study that was published several years ago that documented an 18% decrease in the number of pathologists in the US and Canada between 2007 and 2017. Secondly, much of what we do is straightforward, but also some of what we do is quite time-consuming, prone to inter-observer variability, and or prone to error. And AI can potentially address all of these issues and improve our work life. So how can AI help in the daily practice of pathology? Well, these are some bullets that kind of summarize the state. It can improve workflow and reduce turnaround time. It can level the playing field by increasing accuracy and reducing inter-observer variability. It can provide us with second reads before final sign-out to ensure clinically significant lesions have not been missed, so it can provide a QA function. It can do things we don't like doing, are not very good at doing, or are time-consuming. And most interestingly, it can do things we can't do. So I'm going to take each of these bullets and expand them in specific regard to breast pathology. So with regard to improving workflow and reducing turnaround time, using an AI algorithm can help us prioritize our cases so we can come in and know which cases are likely to have cancer and which require the most attention first. It can highlight clinically important lesions within cases, pre-order receptor immunostains for invasive cancers in DCIS, pre-order additional levels. For example, if a biopsy is done for microcalcifications and the algorithm that's being used doesn't detect any calcifications, the software can automatically pre-order levels to look for the calcifications. It can eliminate the need for immunohistochemistry in some cases. It can pre-populate reports, including synoptic reports. And when you think about it, what are we asking AI to do? Really, it's acting as a super resident or super fellow to take the first read on things. Now, I'm going to talk in a bit of detail about this paper that was published in NPJ Breast Cancer last year, and Judith Sandbank and Anne Vincent Salomon from Institut Curie are in the audience. They're the first and senior authors on this paper, and they can correct me if I say anything incorrectly. So this paper describes the development of an AI algorithm for breast pathology detection in whole slide images of biopsies. And it reports on the results of internal testing, validation in an independent cohort, and deployment in routine clinical use. So let's first talk about the development of the algorithm. So this algorithm is known as Galen Breast. It's received CE approval in Europe. It's based on a fully supervised, multi-layered convolutional neural network and specifically designed to classify and analyze whole slide images of breast biopsies. The algorithm was trained on more than 2 million labeled image samples from multiple labs and manually annotated by more than 20 senior pathologists to establish the ground truth. And the algorithm can identify 51 different lesions and pathologic features of invasive and in situ breast cancers and benign breast lesions. So with regard to the internal testing and validation in an independent cohort, the data set came from several sites, Institut Curie in Paris and Maccabi Health Systems in Israel. 6 senior pathologists participated in the study, and the ground truth was established by independent review by these senior pathologists, and discrepancies were reviewed by a third pathologist. Now, one of the important things about this study is that not all the slides were the same. The images were captured by and generated by 2 different scanners. There were different stains. For example, Institut Curie does an HES stain, hematoxylin, eosin, and saffron. Dr. Vincent Salomon can explain to me at some point why they do that. Maccabi uses standard H&E, which most of us can recognize. The primary endpoints of this study were the performance for invasive cancer detection and performance for DCIS detection, with secondary and exploratory endpoints as shown here. For example, invasive ductal versus lobular carcinoma. So, in the internal test set, about 2,000 cases were studied, and you can see in the fourth column the area under the receiver operator curve for invasive versus non-invasive cancer was 0.998. For DCIS versus benign or other lesions, 0.999. And even for distinguishing invasive ductal from lobular carcinomas, 0.932. These are the data from the external validation set. And you can see that the AUC for the identification of invasive breast cancer was 0.99. Wow, the formatting of this is really weird. I don't know why. But anyway, the AUC for the detection of DCIS was 0.98. Despite the problems with the image, these results were really, really good. Now, in a presentation that occurred earlier this morning at the breast session, the group from Hartford Hospital used this Galen breast algorithm at their own institution as a demonstration of how valuable this is. They studied 475 core needle biopsies, which were enriched for invasive cancer, DCIS, and ADH. And as you can see, the AUC for the detection of carcinoma was 0.975, for the detection of invasive carcinoma, 0.98, and for DCIS, 0.99. You cannot get much better than that. So let's see if this works. Well, you can't hear it. But basically what I'm saying is that this is an H&E image of a cancer with an area of invasive cancer that you can see there, and an area, several areas of DCIS. And you can see that the algorithm has highlighted a high likelihood of cancer as well as a high likelihood of invasive cancer and DCIS. And when you click on the cancer algorithm, you can see that the areas of both DCIS and invasive cancer show red in the heat map. If you click on invasive cancer, you can see that the invasive cancer is highlighted in red. And if you click on DCIS, the areas of DCIS are highlighted in red. So in the external validation set, there is also data on subtyping both invasive cancers and DCIS. For example, in the validation set, the AUC for distinguishing invasive ductal from lobular carcinomas was 0.996, and the AUC for distinguishing intermediate or high-grade DCIS from low-grade DCIS and ADH was 0.92. So here is an image screenshot from the algorithm. And you can see the H&E of a core needle biopsy on the left. And you can see on the right that the algorithm highlighted a high likelihood of cancer and invasive cancer and a low likelihood of ADH DCIS. If you click on the invasive cancer box, you can see again areas of invasive cancer highlighted in red. And furthermore, the algorithm said that this is invasive lobular rather than ductal carcinoma as shown in blue. And when we look at the H&E at high power, this is in fact an invasive lobular carcinoma. Now, at last year's meeting, Dr. Sandbank presented these data showing that using this algorithm result in a 30% reduction in the ordering of immunostains, specifically 19% for benign breast biopsies, 28% for invasive carcinomas, and 44% for DCIS and ADH. So another way AI can help in the practice of breast pathology is leveling the playing field, increasing accuracy and reducing inter-observer variability, and providing second reads before final sign-out to ensure clinically significant lesions have not been missed, serving a QA function. And in the paper, this was described in the routine clinical practice at Maccabi Health Systems. So this AI algorithm was deployed as a second read at Maccabi, serving a QA function, and the algorithm issued alerts during this second read. For example, an invasive carcinoma alert for cases that were originally diagnosed as benign or DCIS or carcinoma in situ, a DCIS or ADH alert for cases initially diagnosed as benign, and the alerts triggered focused pathologist review. So the data presented in this paper indicated that alerts were raised for 363 slides, or 4.2%, originally diagnosed as benign, and 126 slides, or 15%, originally diagnosed as DCIS or ADH. 75% of the cases slides required no change after pathologist re-review, and 25% led to additional sections or stains. This is an example of a case of a core needle biopsy that was originally diagnosed by the pathologist as benign. It was run as a second read on the algorithm, and you can see that the second read said that there was a medium likelihood of cancer and invasive cancer. And when you click on the cancer box, you see a heat map. I don't know how well you can see this, but at the bottom core, there's a little red spot shown at higher power here. When you remove the heat map, you can see this atypical glandular proliferation, seen better at high power here. Immunostains were done. These glands lacked a surrounding P53 myoepithelial layer, were strongly and diffusely ER positive, and what this is a sub-millimeter focus of invasive ductal carcinoma grade 1. So how else can AI help in the daily practice of pathology? It can do things we don't like doing or not very good at doing or are time-consuming, and do things we can't do. So among the things that we don't like doing or not very good at doing or are time-consuming are things like looking at lymph nodes for metastases, and there are AI algorithms that can do that, and quantitating pretty much anything, including mitoses, TILs, Ki67, PD-L1, and HER2. And Ibex does have algorithms to quantitate specifically Ki67 and HER2. This is an example of the Ki67 algorithm, which shows the H&E stain section on the left, the tumor cells highlighted by the algorithm in the center, and providing a density of Ki67 positive cells, which ranged from 40 to 60%, using the algorithm, and the pathology report said 49%. The HER2 algorithm also identifies the tumor cells, and then on a cell-by-cell basis identifies cells with strong, complete staining, weak, incomplete staining, and everything in between. So you can quantify HER2 expression on a cell-by-cell level. Another way AI can help in the practice of breast pathology is do things we can't do. For example, from H&E stain sections alone, predict things like hormone receptor status, oncotype recurrence score, mutations, including breast cancer susceptibility genes, and pathway activation. There are algorithms out there that can now predict outcome, for example, local regional recurrence or distant recurrence, including metastases to specific sites, for example, the brain. Or predict response or resistance to specific therapies, like predict the likelihood of PCR after neoadjuvant therapy. There are a few papers out there that do that. And identify novel types of cancers and biomarkers in a discovery mode. But what are the challenges to implementation of AI algorithms into clinical practice? Well, I think the major bottleneck for many of us is digitizing slides. If you don't have a scanner and you're not digitizing slides, you can't use these algorithms. But more and more institutions are moving toward digitizing slides. And then there are a whole bunch of other issues, including infrastructure considerations, financial considerations, workflow issues, slide staining issues. But one of the benefits of this algorithm is that it seems to be functioning well independently of how the slides are stained. It functioned just as well on HES stains and on H&E stains. File size and storage of digitized slides is becoming less and less of an issue. Of course, we have to know that the algorithm that we're using is reliable and generalizable, and there are all sorts of regulatory compliance, medical, legal, and reimbursement issues that I don't have time to discuss. So, in my view, in the near future, the way AI can help in breast pathology is to improve accuracy, efficiency, and consistency for specific defined tasks, including prioritizing cases, diagnosis and grading, identification of lymph node metastases, quantitating histologic features and biomarkers, pre-ordering receptor stains and levels when necessary, and pre-populating reports. In the longer term, I think we will see more sophisticated AI algorithms that do things we currently can't do. And I think this is where much of the real added value is, because I think ultimately what we want is integration of clinical, radiologic, histologic, biomarker, and genomic data to provide us with a comprehensive computational pathology profile for optimal diagnosis, prognosis, and treatment. So it's quite possible, it's quite possible that I can't move to the next slide. Okay, that this is the workflow of the future, that slides will be produced, they'll be scanned, they'll undergo analysis by an artificial intelligence algorithm, which can then order recuts, immunohistochemistry, special stains as needed. This will be integrated with clinical and radiologic information. Cases can be prioritized and triaged before they're dispatched to the diagnosing pathologist. The AI algorithm can render a preliminary diagnosis, cite other relevant histologic features, report on prognostic and predictive features, and pre-populate reports. This can all go to the pathologist for review, who may or may not want to do a second read using the algorithm to ensure nothing's been missed before final sign-out. So with that, I will stop and move forward to the next presentation by Dr. Krishnamurthy.
Good afternoon, everybody. Thank you for coming. And so I'm Dr. Krishnamurthy from MD Anderson Cancer Center. So after that introduction of AI in breast pathology, I'll be talking to you about the promising potential of AI-based ancillary aid for HER2 immunostain interpretation. So these are my disclosures, and I did a sponsored research study with Ibex, and today I'll be talking to you about the role of ancillary aids using AI for HER2 evaluation. So a little introduction about AI. All of us in this meeting have heard a lot about AI. So what is really AI? So these are pathologist perspectives, right? We are not computer scientists, but we all have understood that it is a team effort. You know, for AI to move in the field, you need the end user to be very happy with everything. So you have your expert computer scientists, you have informatics specialists, but at the end of the day, if the pathologist does not work very well with these other groups, I think the field cannot move. So I think I'm standing here as an expert pathologist, but working very closely with the other members of the team. So AI is basically the ability of the computer software to mimic human judgment, integration of large amounts of data to carry out tasks very quickly and accurately. So if you look at it, I think there has been a significant upsurge in AI applications relevant to the field of anatomic pathology from 2015 to 2016. You may ask, why is that? The reason is that the AI algorithms have matured and they are becoming better and better, and they've become so good that all these applications, there are so many vendors, so many scientists working to bring it to our field. So if you look at the American Medical Association's definition, all these AI applications are defined as augmented intelligence. It is not really artificial intelligence, but augmented intelligence. And the definition is that all this represents the use of tools such as machine learning, deep learning that can enhance rather than replace human healthcare provider. I think we like to hear that because the question always comes, are we going to be replaced? So I think it is becoming very clear in the field that it is augmented intelligence. So the augmented intelligence concept is based on studies that integrate machine learning, deep learning with human experts in a synergistic workflow. And based on existing data, it is very clear that both together gives a better output than each independently. So I think that is good for us. So if you look at applications of AI relevant to standard of care pathology practice, there are several diagnostic applications. You heard from Dr. Schnitt. It is not just for breast, for any area of surgical pathology. The second is determination of prognosis, prediction, response to therapy. I think I myself did a study that led to a patent and licensing with my institution of creating an AI tool for predicting response of triple negative breast cancer to neoadjuvant therapy. There are many coming, for predicting response to ER, predicting response to HER2, you name it. Every now and then you hear a new study in Nature. All these studies are really high-powered studies. The third is prediction or of biomarker expression genomic changes directly from a glass slide. So all these are utilization of whole slide images based on just a routine H&E stained glass slide. However, for a pathologist, I think one of the applications that is very appealing for two reasons. One is that it is very much feasible to do. And the second is that we heard in this meeting a lot about AI, but there is not so much talk about the problem of cost and reimbursement, right? You heard the CAP just brought a utilization code to capture the technical charges of whole slide imaging. So leave alone the professional charges. So the question comes, there are so many tools. Who's going to buy them? How are these people going to move along in the field? But for biomarker estimation, I think there is already a CPT code, and it pays you more than doing a manual evaluation. So that is where I think there is money for all of us. So for today, I'm going to talk to you about the role of AI tools applied to whole slide imaging of HER2 immunostained slide and see what it can do for us. So I don't have to talk to this audience about HER2 as a biomarker in breast cancer. You know that HER2 overexpression or gene amplification happens in 15% to 20% of patients. And people who have HER2 amplification are usually of the high histologic grade. They have all the bad factors like p53 mutations, aneuploidy, and activation of the signaling pathways, the PI3 kinase AKT pathway or PAM pathway. So it's a bad indicator. We all know that HER2 is an important prognostic and predictive biomarker. And for us, as pathologists, we are the ones who help our clinicians to give the patients HER2-targeted therapies. So today's world, there are monoclonal antibodies, tyrosine kinase inhibitors, to kind of treat patients who are HER2 positive. However, in recent years, new drugs are coming, which are called antibody drug conjugates, and these allow the cytotoxic chemotherapy drugs to go in even with very low expression of HER2. So in a phase 3 trial in patients with HER2 low metastatic breast cancer, that means these are patients. So you may ask, what is the definition of HER2 low? That is HER2 IHC 1 plus or 2 plus, but in situ hybridization negative. So in this phase 3 trial, in patients who had HER2 1 plus and 2 plus without FISH amplification, who already received 1 or 2 lines of chemotherapy. So these were metastatic breast cancer patients. They took 557 patients, including mainly hormone receptor positive patients, very few triple negative patients. But their main goal was to see whether it worked on hormone receptor positive patients. Interestingly, this trial got a standing ovation in ASCO because the drug, which is an antibody drug conjugate, trastuzumab and deruxtecan, what is called as TDXT, really gave good results in patients who were HER2 low, not just in the ER positive, but in the overall cohort. If they took the whole cohort, the progression-free survival improved from 9.9 months in comparison to 5.1 months in patients who received a physician's choice of therapy. Similarly, the overall survival improved. So what they started with main goal for ER positive, they ended up learning that it worked very well. So why was this trial very seminal? The reason is all along everything was geared towards HER2 positive patients, but now there was a drug that is FDA approved for even patients who had very low levels of HER2. So what does that mean for a pathologist? So for us now, there is a need that you have to identify these patients very well. So traditionally, you know that USCAP divided our cases into 0, 1 plus, 2 plus, and 3 plus. And there are strict criteria for us, which all of you are aware. And so we divided cases into clearly negative, which were HER2 IHC 0 and 1 plus, 3 plus clearly positive, and we had an equivocal group of 2 plus that we did reflux FISH or ISH or chromogenic in situ, whichever in situ hybridization method. And we again divided them into negative or positive based on the gene amplification status. However, now with the presence of availability of drugs that can be given to patients who have low levels of HER2 protein, that means which can be given in HER2 1 plus and 2 plus that are FISH negative. So the 2 plus FISH negative is easy. But remember, our negative is no longer just negative. Your negative gets divided into true negative, which is cases that has no staining or less than 10% weak, incomplete, barely perceptible membranous staining, as well as 2 plus, which is weak or moderate, complete membranous staining in more than 10% of tumor cells. So our classification that was geared to identify amplified cases that were 3 plus or 2 plus that showed FISH or ISH positive now becomes slightly different. So HER2 low breast cancer, what is it basically? As I told you, it is patients who have HER2 IHC score of 1 plus or 2 plus and in situ hybridization negative. So the estimated overall frequency is around 59%. It is a very heterogeneous group. Majority are ER positive cases and 30% or so are triple negative. So one thing we all have to understand is that there is tremendous intratumoral heterogeneity that causes problem for us in identifying patients who are HER2 low. So if you did a core biopsy, you may get a certain percentage, but if you switch to a bigger tissue, you will get a different percentage because there is a lot of heterogeneity in the protein expression at the lower end of the spectrum. So right now, so why is it that there is so much buzz about HER2 negative versus HER2 low? The problem is that for rightly so, right? At the lower end of the spectrum, we were never paying attention. We said it does not matter, right? Whether you called it 0 or 1 plus. Some people would just put 0/1 plus, 0-1 plus. But now you are asked to separate 0 and 1 plus. So at this lower end of the spectrum, based on the existing reports, it is very understandable that there is substantial inter-rater discordance and poor reproducibility in distinguishing 0 versus 1 plus. If you look at Dr. Rim's paper, they say there was only 26% concordance. However, in that study, the pathologists were not told that this was the intent of the study. Our own study from MD Anderson, we found that with an intent to identify HER2 low, between pathologists, it's not that bad. It's close to 80%. But nevertheless, there is a problem at the lower end when there is like borderline. Is it really 0? Is it 1 plus? Is it 1 plus or is it 2 plus? I think that problem, and we as experts say that at the lower end of the spectrum, short of not having any other objective tool, all you do is take a consensus score, right? That's all you can do. So there is a lack of a reference standard that increases the probability of false negative or false positive identification of HER2 low. But for the standard, what we were doing so long, HER2 negative versus HER2 positive, we had an arbitrator as in situ hybridization. Everything was pretty good for us. But now this new challenge of identifying HER2 low is an issue. So what are the issues related to identification? Current HER2 IHC assays are designed to identify HER2 amplified cases, and they may not be the fit for purpose test to identify HER2 in the low dynamic range. There is no reference standard to validate an IHC assay's ability to distinguish 0 from 1 plus. So pre-analytic factors are very important. Provided your pre-analytic factors are good, the extent to which tissue heterogeneity also affects your identification of HER2 low is really not fully known. So IHC may not be totally reliable in detecting HER2 low. We know all that, right? But the drug, the antibody drug conjugate that is FDA approved, it may even be positive in HER2 ultra low cases, right? In patients who have even little bit of protein. So all these are issues that are being. With that, I think I want to just tell you that as a pathologist, looking at HER2, identifying HER2 at the lower end of the spectrum is a challenge. Imagine you have a core biopsy with lot of tumor and you want to see weak focal areas of, low level of expression. It is time consuming. There are guidelines for you. For 0 and 1 plus, you are supposed to look at 20x and go at 40x, right? And it takes time. So what is there for us? That is where I'm going to talk to you about the study, an AI tool as an ancillary aid for, okay. So I think as an ancillary aid to help you in kind of scoring cases. So it is a preliminary study. It's the Galen breast HER2 study. So the first aspect of any algorithm is identifying invasive cancer. So you see here, the algorithm has to identify the invasive cancer, and then it marks for you based on the, the HER2 immunostain on the cells. So this is how it does. See, it has different annotations if the cell is 0, 1 plus, 2 plus, or 3 plus. And so it marks for you clearly based on these colored annotations. Each, like a green is a weak, incomplete, a blue is like complete negative staining. And at the end, it gives you a percentage of cells with each of these scores. So this clinical validation study of a fully automated AI system was done using 5 breast pathology experts as the ground truth and 4 surgical pathologists in general practice. So the data was collected with and without AI help. So 120 cases collected from different labs with different scanners and then given to these 5 breast pathologists. And for the majority of the ground truth, 4 of the 5 pathologists, if they agreed with the diagnosis, then that was considered as the truth. Weak kind of majority was 3 out of 5. And the case distribution was pretty fair. It had 0, 1 plus, 2 plus, and 3 plus based on the standard kind of prevalence in routine practice. So amongst the pathologists, the inter-observer agreement was 72.8%. And full consensus was reached only in 44.2% of the cases. So you can imagine, even amongst the pathologists, rightly so, as we expected, there is not full consensus. So, but then if you look at the cases, in the majority of the cases where there was lack of consensus was this ones which were 0 and 1 plus, which formed the majority of the cases where even the experts did not really agree. So, but if you look at the performance of the standard pathologist with and without AI, overall, their agreement with the ground truth, it was 81.9% versus 88.8%. You may say that is not really that great, but look at the inter-observer agreement with AI, it really improved. But more so, I want to show you this one, that if you took overall pathologist performance with and without AI, the inter-observer agreement also kind of improves if you use an AI tool. And if you look at the AI standalone performance compared to the ground truth of the breast pathologist as experts, 4 of 5, it did pretty well. You see, for 0, it was 92.6, and for 3 plus, it was really 100. It did little, not that great for 2 plus, but it did pretty well for 0 and 1 plus, right? So examples, I can show you some examples. Because of lack of time, I will just maybe skip through and just tell you the real cases. So what is the advantage for you? you may say that at the lower end of the spectrum, if here is the case, it's hard to kind of see where there is incomplete staining. And if you use the tool, see here, this green, I don't know how much you can see, it clearly marks your areas that are 1+, and it gives you a total percentage of those cells. So I think, these borderline cases where you're debating whether it is 0 or 1+, if you use the tool, it makes it more objective to give you a percentage of the cells that are 1+ or 2+. So I think here is another case, like, very weak. It looks as though everything is negative. Maybe there is a little bit of staining there. See how beautifully it shows you here. See, it marks for you that what to the eye looks like something is positive. Majority of them are negative, except this little area where there is some incomplete staining. So there is little bit here, little bit here. This case was called by some experts as 1+, some as 0, but using the tool, it became clear that it is a 0. So I think I may skip that. So the bottom line is, like, what is the role of an ancillary tool, right? So in this study, giving it to the hand of an ordinary general surgical pathologist who is not a breast expert, with and without AI, their performance becomes closer to the breast experts. Amongst them, there is more concordance, and particularly at the lower end of the spectrum, the tool really makes it better to create that inter-observer concordance, and it creates their scores closer to the breast experts. So in conclusion, so in this study, taking a reliable ground truthing as taking the opinion of 4 of the 5 breast experts as the gold truth, I think, consensus was reached only in 76.7% of cases. So you see the problem even for the experts, rightly so, right? It is subjective at the lower end of the spectrum. So pathologists without AI had a concordance rate of 85.3% overall. However, when you took cases at the lower end of the spectrum, their concordance became better. So what would I say? Ancillary AI tools may be particularly useful for borderline cases at the lower end of the spectrum of HER2 protein expression. So larger studies are needed to substantiate these findings to demonstrate the potential utility of AI-based tools for HER2 IHC interpretation. So it is promising, but we have to learn a little bit more. This is just 120 cases done with like 9 pathologists. So you have to generate more data to get more confidence. But clearly, it is a more objective tool that is going to help us to identify patients at the lower end of the spectrum, not necessarily for the higher end that we have FISH and chromogenic in situ as arbitrator. But for the lower end, we need something that is good, and I think this could be a great solution. Thank you very much.
Good afternoon. So I will start my talk by making 2 statements. I'm completely naive when it comes to this. First thing is I don't have conflict of interest with Ibex, so I'm completely naive. And the second thing is that my experience is very, very limited. And my point is really to make some statement, I think, as a senior GI pathologist, as how I see the field in the years to come. Everybody's talking about, obviously, artificial intelligence. And there was this very interesting commentary in the New York Times a couple of months back, but I think it's important to read. The alien invasion has begun. Some experts say that when artificial intelligence takes off, it's going to be like Martians landing on the National Mall. And then you can read a little bit further. When artificial intelligence pass their rebellious teenage phase and then hurtles into adulthood, it's not so artificial anymore. We will be relegated to being family pets, as resigned Steve Wozniak put it. And I remind you that Steve Wozniak was the co-founder of Apple. And I love family pets, but I just don't want to be like Ranger, my grand dog. So artificial intelligence, we all are aware, and I'll pass on this quickly to keep going, has been increasingly applied in medical imaging. different techniques are being used to extract the data and come to the results that we've shown a little bit recently and just previously. To keep moving, there has been an increased number of papers published in PubMed. Everybody can come to that conclusion. AI is here and is here to stay. When it comes to GI and GI pathology, I think it's a unique field, because obviously already our gastroenterologists, by virtue of what they do, collecting images endoscopically, have been already in that field in different aspects. And I picked up 4 papers. The top one is deep learning in the decision making for gastric neoplasm. So clearly helping the gastroenterologist to target their biopsy. The second one, which I think is very important as well, is the role of artificial intelligence in the monitoring of inflammatory bowel disease. And as you know, when it comes to the management now of patients with IBD, the histologic actually quality of a decrease of inflammation is more important actually than even the endoscopic appearance. So actually they're trying to catch up on us. And you can see the next 2 papers also in the detection of polyps and in squamous neoplasia. So in every aspect, so to speak, of gastroenterology, already artificial intelligence is important. So I think that the field is ripe when it comes to GI pathology. And this is what I get for breakfast, when I come to work. There's a second serving a little bit later. And obviously, when it's come to GI, we all deal with high volume, and it's growing. We know that. Our endoscopists are taking more and more biopsies. So we need helping hands and screening, what Dr. Schnitt calls super fellows or super residents. Those are the helping hands. What we do is clearly repetitive. One polyp after a polyp is still a polyp. We have some well-established histopathologic patterns for many conditions, and as well as for differential diagnosis. We use routine immunohistochemistry in inflammatory settings, as well as the neoplastic settings, MMR, PD-L1, HER2/neu, and I can tell you as a GI pathologist, if I can get rid of PD-L1, I'll be more than happy. So if we go back to some data, and Dr. Sandbank, who is on the first row here, is the unsung hero of this presentation. There has been some studies done in gastric neoplasia, again using the Galen system in the evaluation of gastric biopsy. So the same type of evaluation, and I just want to move forward so we can get to the end of this presentation. Multiple biopsies were reviewed by a cohort of 10 pathologists. There was a ground truth being said there. There was any discrepancy was educated by 2 GI pathologists, and then was a comparison between the histologic ground truth by the morphologist and the AI, looking not only at neoplastic conditions, but also at inflammatory conditions. You can see 109 carcinoma, dysplasia, and high-grade lymphoma, so a big bulk of GI, of gastric neoplasia, and 622 cases of inflammatory conditions. And if we look at the data, you can look at the performance here again with when you're looking at inflammatory condition, Helicobacter pylori gastritis and related gastritis, an AOC of 0.97. That leads to a positive predictive value of 68, but also a very strong negative predictive value of 98%, which for a screening tool cannot be much, much better. So one thing, when you look obviously at AI data, it's a degree of probability which is used in this heat map shown up there. So one example, just to put some few pictures, a nice example of Helicobacter pylori gastritis with obviously this band-like superficial inflammation. You can see also there is activity if I was going at higher magnification. And you can see that the Galen Ibex system clearly identify the quality of the inflammatory infiltrate and the activity, showing here with this high probability with this red color in the heat map. Looking then on the other aspect, the neoplastic condition, you can see an AOC of 0.99, again, leading to a negative predictive value of 99%. So obviously, the system is a wonderful screening and diagnostic system leading always to the hotspot, so to speak. And when it comes to GI biopsies, this is what we do. It's always looking at something in a haystack, right? There is 10 fragments there, and if I could look at this in 10 seconds, that will be great. It usually takes me a little bit longer. So it's looking for the needle in the haystack. You scan the slides, and this is a slide that was scanned in my institution in Florida, sent on the other side of the world, and you can see immediately then the system immediately located an area of concern. We go at higher magnification, and the diagnosis here, we can see of carcinoma, obviously, as demonstrated on the left side, was picked up very easily at low power by the Galen Ibex system, which is highlighted again here with the red color on the heat map. And then you can come up and say, I found it, you found the needle in the haystack. Another example that where I tested the system, I just want to believe. So I tested the system, sent a case, another gastric biopsy. As you can see here, there is no significant lesions that can be identified at medium size magnification. You scan the lesion, there was maybe something atypical right there, so let's go at higher magnification. And the system immediately and very easily made this diagnosis, picked up this CDH1 deficient hereditary diffuse type gastric cancer. And as you know, those patients, we get hundreds and hundreds of biopsies to detect those foci before whether or not we decide for these patients to go to a prophylactic gastrectomy. And there was a very good presentation by my friend Fatima Carnero on Sunday. And with this, immediately you can say, I'm a super pathologist, and make the diagnosis immediately. Finally, I always like to say I'm a super pathologist, so I may finally get there with a system. One more example here, a low power gastric biopsy. There's clearly nothing very striking there, some inflammation, some maybe irregularity here that I circled. The system picked up on this area as well. You go at higher magnification, and here you can see this infiltrative synanchoid cell carcinoma, or polydiscohesive gastric cancer. And you can see that even at high magnification on H&E, the diagnosis is not so easy. Obviously, was confirmed by infiltrating a cell by immunohistochemistry, and then here there was no error. So where are we going for GI? And obviously it goes beyond gastric pathology, and I had some discussion already with Dr. Sandbank, because this can be applied to many things in GI pathology. To repeat many things that have been said by my friend Dr. Schnitt, we always do say what I would like to say much better than I do, is you can improve accuracy and efficacy. It's clearly a screening tool where we, in high volume practice, we can use in the setting of shortage of pathologists. It can improve our performance, increase pickup rate, guiding diagnosis, not only in neoplasia, but in inflammatory condition in the GI tract. It can narrow the differential diagnosis. It can also prevent potential suboptimal performance, which is a very nice way to say we won't screw up. It can lead to something specific, which is important in my opinion, standardization of subjective scoring, dysplasia. As a GI pathologist, low grade, high grade, there's always, I think we can work on this, on the standardization of dysplastic lesion. Improving and standardizing IHC scoring, I won't repeat what was said before, and evaluation of therapeutic response. For the non-believer, I think that we need to look at, and seriously at some issue as well, we need to balance clearly the role of artificial intelligence and the human diagnosis. It's important, but our jobs are there to stay, not worry. An autonomous diagnosis by AI is clearly not recommended, and we just have to think like pilots in the airplanes. You know, if you're on the Boeing 747, a lot of flying is done by the computers these days, but you still have a pilot and a co-pilot, so we need to stay there. I think the only thing we just need to worry as well, and probably in the residency program, is the risk of decreasing the medical skills. We just don't want everything to be done by artificial intelligence, but collaboration is the key. Thank you very much.
Good afternoon, everyone. I'm Dr. Saira Shah, representing from Quest Diagnostics. We are honored to be a part of this platform. We are pressed on time a little bit. I'll try to be as quick as possible. I'll be sharing our experience with a pilot study that we did at Quest Diagnostics with the prostate. And we teamed up with the Ibex team and the Shah team, and we created a pilot. The study essentially had 200 prostate core biopsy cases, and our main incentive with this study was to see what's the positive impact on our business, essentially how it affects the turnaround time, how accurate it is, and its usability. So the pilot study had two arms. The arm on the left, we used only the Concentric DX. It's a software platform provided by Shah. And on the right side, we use Concentric DX with application of Ibex AI. 3 pathologists participated in the study. There was also a 4th pathologist who basically played the role of an adjudicator and only reviewed the discrepant cases. High-quality slides were prepared at Quest Diagnostics lab in Tampa. We used the Leica scanner GT450. We had very good experience with it. The scanning would start as soon as the slides are loaded, and we did not have any issues with them. The slides were presented to our signing out pathologist. This is the platform by the Shah. It's called Concentric DX. It's the digital slide tray. So after application of Ibex AI, as you can see, the slides were color-coded. Our pathologists really enjoyed this feature. So the slides with the cancer were coded and presented to our pathologists as red. The more of the benign cases were color-coded as green. Our pathologists really enjoyed this feature because they can actually prioritize this case. In the morning as they come and they're having their first cup of coffee, they would see, okay, there are 4 cases, let me look at those 4 cases first. And they would essentially order immunostains if needed. Our lab usually takes about 4 hours on the immunostaining, and we would receive the slides by lunch or after lunch, and the cases were signed out essentially the same day. And the same works for the QC. We do mandatory QC for all positive cases. So as this was provided to our signing out pathologists, they would prioritize their cases. The QC cases would go first, and the immunostains, if needed, would go also first. This is the platform that was provided by the Ibex AI. As you can see on the right side, these were different heat maps that were provided by the Ibex AI system. On here, we see a core biopsy with evident cancer. There's small focus of perineural invasion also. And on the right side, you can see all the heat maps that are provided by the Ibex AI. Not only there was a heat map for cancer, but also for Gleason scoring, perineural invasion, high-grade pain, inflammation, and atrophy, and so on. So now the same core biopsy with the application of AI, the tumor is nicely presented, color-coded, high probability. The red would indicate high probability. The green-yellow would more of a low probability, medium probability, and the blue more of a low probability. The same core biopsy with the Gleason heat map application. The red indicates the pattern 5. The green and yellow more of pattern 4, and the blue would indicate pattern 3. The same core biopsy with a small focus of perineural invasion that's embedded in the tumor was nicely highlighted by the perineural tumor, invasion heat map. I'm sorry. Another core biopsy with different spectrum of tumor here. In the center, more of pattern 5. On the upper, more of a pattern 3. And the one on the left, more of a pattern 4 with application of the Gleason heat map. Very nicely highlighted. The red indicated pattern 4. The blue on the top indicated pattern 3. And on the left, the more of the pattern 4. A small focus of tumor. We as pathologists see this, and these are malignant pitfalls that we face in every organ system. This was a very small focus of tumor with the application of Ibex AI. It was very nicely highlighted with red indicating high probability of cancer. A case of atrophy. There's also a heat map for atrophy. I just want to breeze through this one. So on the completion of this study, our main incentive was to find out how it affects our business unit. What's the positive impact? Does it affect our turnaround time in terms of how fast these cases are signed out, and also the effect on immunostains? Another key factor that we wanted to study was AI performance, how in terms of diagnostic accuracy, in terms of accuracy of Gleason grading, in terms of accuracy of perineural invasion, and so on. And of course, our pathologists. We wanted to see how our pathologists do. Were they receptive after having this pilot study done? How was their experience? Were they willing to participate in this on a clinical ground? So here, in terms of efficiency, the higher bar, you would see the time our pathologists took without application of AI, and the shorter bar indicates the time it took with application of AI. So in terms of productivity, our pathologists were signing out 2.4 times more cases. Here, I just want to point out the higher bar looks a little way too higher, but just want to explain over here that, for example, a prostate case have 12 parts. Every part have 2 slides. For the purpose of this, usually we render a diagnosis on every part. But for the purpose of this study, in order to generate more data, we were rendering diagnosis on every H&E slides. So that kind of doubled our the turnaround time. That's why you're seeing 50 minutes. But it was an acceptable thing that we had to agree on. But we were most interested in the comparison. The comparison between the read with the Prussia concentric DX versus when Ibex AI is applied. So there was a significant decrease, 58% decrease in the sign-out time. Not only that, we wanted to study if all the participating 3 GU expert pathologists were having the same experience. The first pathologist decreased his sign-out time by 58%, the second 61%, and the third 56%. In addition, we saw the decrease. We were actually expecting the decrease only the malignant cases, but we were surprised that the decrease in the turnaround time was consistently seen in all the diagnoses, benign, the undetermined, and the malignant. So we were very happy with that. In terms of cancer detection, we were very impressed. All the cases, there was 99.7% of the positive cases that were read malignant by our pathologists was also read malignant by the Ibex AI software. Only have to point out one case that was read by our GU pathologist as malignant, but the software missed it. It was a small case. I think it was a pattern 4 with little stroma. So that was the only case. But we had excellent results, negative predictive value, 99.9%, positive predictive value, more of 100%. So we were very happy with those. In terms of Gleason grading, if you combine both the full and the partial agreement, we had very high at about 90% agreement on Gleason grading. Another feature that our pathologists were very happy and very impressed with, that the Ibex AI not only picked up the foci of perineural invasion that our pathologists picked, in addition to that, it also picked up 5% more cases. So that's something that our pathologists were really happy with. Impact on IHC. As I think I've already covered this, the cases were presented in a prioritized way to them so they could, order their immunostain ahead of time. And also, with the application of Ibex AI, we saw that there was a decrease in the ordering of immunostains. So that was also a business gain that we saw. More of the things I've already mentioned here, also the QC, as the cases were presented to our pathologists more in a prioritized way. The pathologists had the ability to QC them. For us, it was a win-win situation. We had an excellent experience. All of our pathologists were very motivated with the study, and they are very likely to use this software. And as we speak, I think we will try a few more organ systems as well, like breast and GI at Quest Diagnostics. A big thank you. We worked as a team, all of us, at Quest Diagnostics, Ibex, and Proscia. Both the teams of Ibex and Proscia, they were there. They provided us with a lot of support that was needed. And I do want to acknowledge our Quest Diagnostic GU team, in particular, Dr. Brokowski, who led the project. In addition to Dr. Brokowski, we had our other GU pathologists, Dr. Zhao, Dr. Dedloff, and Dr. Michael Choi. And thank you so much.